All right, so a very good evening, everyone. Right, so I hope I'm audible and visible to all of you. So just give me a quick thumbs up, like once, and if I'm audible and visible to all of you. All right, so now let us just go ahead with the second part of the acid-base interpretations. So we have discussed in the previous session that the acid-base interpretations I'll be discussing in two sessions. So in the first session, I have taught you like how to decide the primary acid-base disorder, and I have discussed like how to make out whether it is fully compensated, partially compensated, and uncompensated. So this is what we have discussed in the first session. Right now, what is that I'll be discussing in the second part of the acid-base disturbances. So mainly I'll be discussing the gaps, right? And what is that gaps that I'll be discussing in this particular session is, one is the anion gap, and I will also discuss what is corrected anion gap. Then we have delta gap that need to be discussed, and few more multiple choice questions in the topic of the arterial blood gas analysis. Okay, right. So yes, very good evening everyone. And those students who did not watch my first part of the acid base interpretations, please watch that. That will be definitely useful for you for your upcoming Neet PG exam, right? So having said this, now before going ahead with the gaps, right, before going ahead with the discussion of the anion gap, delta gap, corrected anion gap, I have few more questions that need to be discussed, right? Yes. Now let us discuss these questions and then we will move on to the next question. Right. So again, what did we discuss? We have discussed that if you have a lengthy clinical based question, just try to read the last sentence, right? Or otherwise, we'll try to take up the entire question. A 6-year-old boy was rushed to the hospital following her mother's complaint that her son has been vomiting, nauseated, right? Vomiting, nauseated, and has overall weakness. After a series of tests, the nurse notes that the following laboratory results. Potassium is 2.9. Which primary acid base imbalance is this boy at risk for if metabolic intervention is not carried out? Yes, any one of you, please answer this question. Which primary acid base imbalance is this boy at risk for if medical intervention is not carried out? The options are respiratory acidosis, respiratory alkalosis, metabolic acidosis, metabolic alkalosis. So what do you think is the correct answer to this question? Right. So what is a very important point in this question? Okay, so we have the answers like coming up as C and as well as the D. So very good, Sangeeta. So the answer is the metabolic alkalosis. Now why? Because the individual has what is the complaint within Dave, 6-year-old boy? Complains that the individual is having vomiting and because of which there is overall weakness. So an individual who is like continuously vomiting, what do we anticipate that the HCl is out? Okay, and what is left out now, that will be alkali. So that is the reason why we consider that the patient is having the metabolic alkalosis as a primary acid base imbalance. Then what will be the compensatory event? With compensatory, respiratory acidosis will be there, but primary acid base abnormality will be metabolic alkalosis. So the answer to this question is D. It is not your C. It is your D. Okay, right. So having discussed about the question, right, please answer this. A 24-year male found in state of loss of consciousness at a mall. In emergency department, the arterial blood gas analysis is being performed, and this is the ABG. pH is 7.25, PCO2 is 60 millimeters of mercury, oxygen 65, bicarbonate 26, sodium 137, chloride 100. So what do you think is the answer to this question? So if you observe here, like the pH, how much is the pH? 7.25. It is decreased. and you take the carbon dioxide. How much is the carbon dioxide value? That is 60 millimeters of mercury. So when it is 60 millimeters of mercury, like what do we consider? The carbon dioxide levels are elevated. Then what has happened to bicarbonate? Bicarbonate is 26, which is normal. Now with this data, can anyone answer this question? Right, with this data, can anyone answer this question? So, like carbon dioxide has increased, but your bicarbonate did not change at all. Actually, what should happen? When carbon dioxide increases, your bicarbonate also should increase as a compensatory event. But bicarbonate did not change. The normal value of bicarbonate is 22 to 26 milliequivalents per liter. So bicarbonate did not change at all. So that means it is uncompensated. Right, that means it is uncompensated. Right, very good, Jairam, and as well as Metroid and Elsa. So the answer is uncompensated respiratory acidosis. Why respiratory acidosis? Because what is the primary event here? The primary event, see, both of them, the pH and PCO2 are changing in opposite direction. So the primary event will be respiratory, and respiratory, what, the carbon dioxide value is increased. So that is the reason why we call it as the primary respiratory acidosis is the answer in this question. And that way it is uncompensated. Why? Because bicarbonate did not change. Right, now having said about this question, we'll move on to the next. Yes. A 60-year male with amyotrophic lateral sclerosis is brought to the clinic, okay, with history of somnolence then compared to normal. Also, patient is complaining of the headache, right? Also, the patient is complaining of headache, morning headache, and does not feel refreshed when he wakes up. The ABG is given to you. pH is 7.37, PCO2 57, and the bicarbonate is 34. Bicarbonate is 34. Okay. Now, what acid base abnormality is this patient having? So pH is like normal, and PCO2 increased. Bicarbonate is also increased. So what do you think is the primary acid base abnormality in this patient? Now, when the pH is normal, right, how to decide the primary? When the pH is normal, how to decide the primary acid base abnormality in the individual? Yes, can anyone answer this question? So, when the pH is normal in this patient, yes, I'm waiting for the answer. I'm waiting for the answer. So when the pH is normal, like how to decide the primary event? That is based on the disease the patient is having. What is the patient having? The patient is having amyotrophic lateral sclerosis. In amyotrophic lateral sclerosis, there is involvement of both upper motor neuron and as well as the lower motor neuron. And what is the cause of death in patients with amyotrophic lateral sclerosis is, that is respiratory paralysis. Respiratory paralysis is the cause of death. Why? Because in amyotrophic lateral sclerosis, at the end, there will be respiratory muscle paralysis. Right? At the end, there will be respiratory muscle paralysis. So once there is respiratory muscle paralysis, the individual will end up in respiratory paralysis, causing the death of the individual. And once there is respiratory muscle paralysis, what will happen to carbon dioxide? Carbon dioxide washout does not occur. So there will be increase in your carbon dioxide levels in the patient. So this will be the primary event. Right, this will be the primary event. So that is the reason why in this patient, what do we consider it as? The carbon dioxide is increased as a primary event, and bicarbonate is increased as a compensatory event. But the bicarbonate which is increased is in equal proportion to that of carbon dioxide. That is the reason why the pH is normal in this patient. So we call it as fully compensated respiratory acidosis. Right, we call it as fully compensated respiratory acidosis. So now, if you don't know that in patients with amyotrophic lateral sclerosis there is respiratory muscle paralysis, then you will not be able to make out which is the primary event in this patient. So you should also have the knowledge of amyotrophic lateral sclerosis in this question to solve, right? And if you don't know, then it will become difficult for you to make out the primary. Right. So you see the next question. Cushing syndrome, the arterial blood gas analysis is being done, which results indicate that the ABG derangement is compensated. Which results indicates that the ABG derangement is compensated. The pH is 7.32, PaCO2 18 millimeters of mercury, bicarbonate 8 milliequivalents per liter or 8 millimoles per liter, partial pressure of carbon dioxide 48 millimeters of mercury. So what do you think is the answer? Or how do you, when do you consider that this particular ABG derangement is compensated? Okay, so first of all, can anyone tell me what will be the acid base abnormality in patients with Cushing syndrome? If you know this, then you will be able to answer this question. What will be the acid base abnormality in this patient? Okay, so Trilok is saying A, Metroid is saying C. Right, now let us just take up. So what is the acid base abnormality that you will have in patients with the Cushing syndrome? That is the first important thing that you need to know. So in patients with Cushing syndrome, there will be hypokalemic metabolic alkalosis, right? Hypokalemic metabolic alkalosis. Now you may ask me the question, why there will be hypokalemic metabolic alkalosis in patients with the Cushing syndrome? That is because in patients with Cushing's there is increase in your steroid levels, and once there is increase in steroids, this increased steroids will go and activate the epithelial sodium channels, right? Will go and activate the epithelial sodium channels. When the epithelial sodium channels have been activated, what will happen? There will be increased sodium and as well as water retention. There will be decrease in H plus ions and there will be decrease in K plus ion. So once there is decrease in H plus ion, what do we call this as? This we call it as the metabolic alkalosis. This we call it as the metabolic alkalosis. Now, the point you have to understand here is that when there is metabolic alkalosis as a primary event, that means what is happening to your bicarbonate value? The bicarbonate value is increasing. So when bicarbonate value increases, what should happen to your carbon dioxide value for compensation? Even your carbon dioxide value also should increase, right? Even your carbon dioxide value also should increase as a part of the compensation, because if you take my first part of the ABG analysis, what did I tell you, right? So I have given you one formula, that is H plus ion is equal to partial pressure of carbon dioxide by bicarbonate. Okay, this is the formula that I have taught you. So that means when your bicarbonate increases, then partial pressure of carbon dioxide also should increase. Then only the H plus ion will remain constant. You understand? Or in other way around, when your carbon dioxide decreases, even your bicarbonate also should decrease. Then only the H plus ion will remain constant. So what has happened in this patient? In this patient, there is metabolic alkalosis. That means your bicarbonate is increased. So in response to that, what should happen to your carbon dioxide? Even carbon dioxide also should increase. So when carbon dioxide is increasing, right? So what is the compensatory event here? That is D, partial pressure of carbon dioxide 48 millimeters of mercury, right? So that is the correct answer in this question. Okay, so the answer here is D. I hope everyone has understood this question. Right. So if you have understood this question, just give me a quick thumbs up. And if anyone did not understand, please let me know. I can explain to you once again. Right. So if you have understood this question, then we'll move on to the next one. Right. We'll move on to the next one. Okay. Very good. So you see the next question. Post-operative knee surgery, patient has been receiving analgesia 4 milligrams IV every 2 hours. Respiratory rate is 8 per minute and the patient is drowsy. Patient is at risk for respiratory acidosis, respiratory alkalosis, hypokalemia, metabolic acidosis. Okay. So now can anyone tell me which particular analgesic agent is this patient given? which particular analgesic agent this patient is being given. So the analgesic agent this patient has been given is like, okay, very good. So the answer is the respiratory acidosis. So you should understand that the analgesic agent which has been given to this patient is morphine, which is nothing but opioid. So why is that you are considering that the patient is being given morphine? That is because the opioids, what do? They decrease the respiratory rate by suppressing the respiratory center. So when the respiratory rate is reduced, there will be increase in your carbon dioxide levels. There will be buildup of your carbon dioxide. So once there is increase in your carbon dioxide, what do we call this as? We call this as the respiratory acidosis. So the answer to this question is A. That is the first option, right? Now we'll move on to the next one. A patient consumed a bottle of the aspirin tablets. Which of the following condition is this patient at risk for? Hyperkalemia, hypercalcemia, respiratory alkalosis, respiratory acidosis. Yes. Now, what is another name for this aspirin? The another name for this aspirin, it is acetyl salicylic acid. Right, acetyl salicylic acid. Yes, Radhashri, where can we find annotated PDFs of all these? Okay, so this annotated PDFs, you can just get it in my Telegram channel, right? My Telegram channel is Medicine Made Easy by Dr. Rajesh Gubba. So in my Telegram channel, I have posted already all the PDFs. You can download it from there, okay? And if you're not able to find out, you can just text me on the Telegram channel. I will reply you back. Okay. So, right. So now this patient aspirin consumption, what is this? It is acetyl salicylic acid. So the patient is at risk of metabolic acidosis, right? So once there is metabolic acidosis, what will be the compensatory event? The compensatory event will be the respiratory alkalosis, right? The compensatory event will be respiratory alkalosis. Okay, so because metabolic acidosis is not given in our option, then what would be the answer? The answer would be the respiratory alkalosis, right? So the answer is C. Okay, next. Now a patient is having respiratory alkalosis. What is the most classical sign which is seen in this patient? Bradypnea, Chostek sign, bradycardia, Hoover sign. Not bradycardia. Okay. Now, where do you come across this voluntary respiratory alkalosis that can be seen in the patient? Like, for example, let us just assume that the patient is malingering. Right? The patient is malingering. Okay. And what form of malingering the patient has? The patient has come to the emergency department. Okay. And he is acting in such a way that he is having respiratory distress. Okay, he is acting in such a way that there is respiratory distress. So whenever there is respiratory distress, what will happen to the respiratory rate of the individual? It increases. So once the respiratory rate of the individual is increased, what will happen to carbon dioxide levels? Decreases. There will be carbon dioxide washout. There will be carbon dioxide washout. So once there is carbon dioxide washout, that we call it as the respiratory alkalosis. Right, this we call it as the respiratory alkalosis. Now whenever there is respiratory alkalosis, because of this increased respiratory rate which is voluntarily done by the individual, this respiratory alkalosis will shift, right, will shift the extracellular calcium to the intracellular compartment. right, to the intracellular compartment. So thereby what will happen to your calcium levels, the ionic calcium levels? The ionic calcium levels, that will be reduced. And once the calcium levels are reduced, what is the sign that you get? That is the Chostek sign, right? That is the Chostek sign. So the answer to this question is B. The answer to this question is B. All right. Now, so after having discussed about what will happen in respiratory alkalosis, what is the sign that you can have? Right. Please answer this question. A patient is having the arterial blood gas analysis of partial pressure of carbon dioxide as 25. Okay. CO2 is 25. pH is 7.5 and bicarbonate is 19. Which of the following could not be the cause of this condition? Which of the following could not be the cause of this condition? Anxiety attack, partial pressure of oxygen by FiO2 less than 100, hysteria, aspirin toxicity. Okay, so what has happened to pH? Increased. What has happened to carbon dioxide? Decreased. What has happened to bicarbonate? Even this is also decreased. So your pH and PCO2, both of them have changed in opposite direction. Then what is the primary acid base abnormality here? The primary acid base abnormality will be respiratory. Respiratory what? The pH is increased. So the primary acid base abnormality will be primary respiratory alkalosis. Primary respiratory alkalosis with metabolic acidosis. With metabolic acidosis. Okay. Now the question asked is what? In which of the following condition you will not have this? You take anxiety attack. In anxiety attack, there can be respiratory alkalosis. Just now we have why? Because in anxiety attack, there will be increase in your respiratory rate, and that will cause carbon dioxide washout, and that will result in respiratory alkalosis. Then you take the hysteria. What is hysteria? The hysteria is nothing but again it is a form of malingering. And whenever there is hysteria, the individual's respiratory rate is increased, and once the respiratory rate is increased, there will be carbon dioxide washout resulting in respiratory alkalosis. Okay. Now you take an aspirin toxicity. In aspirin toxicity, the primary acid base abnormality will be metabolic acidosis. Okay. The primary acid base abnormality will be metabolic acidosis. Compensatory will be respiratory alkalosis. Okay. Whereas you take the second option. The second option, PaO2 by FiO2 less than 100. Now, in which condition you will have PaO2 by FiO2 less than 100? So PaO2 by FiO2 less than 100, you will have this in patients with severe ARDS. Right, patients with severe ARDS, you'll have PaO2 by FiO2 less than 100. Okay, now see, like PaO2 by FiO2, if it is around 200 to 300, mild ARDS, and if PaO2 by FiO2 is around 100 to 200, that is moderate ARDS, and PaO2 by FiO2 less than 100, severe ARDS. And in severe ARDS, please remember that the patient will have respiratory acidosis with metabolic alkalosis. So what do you think is the correct answer now? The correct answer here is the best answer. Actually, you have two answers. One is B and as well as D. But if I want to make up only one, then let us just assume, let us take up the answer as PaO2 by FiO2 less than 100. Okay, PaO2 by FiO2 less than 100. You see that in patients with the severe ARDS. Okay, right. So I hope everyone has understood this question. Just give me a quick thumbs up. Just give me a quick thumbs up if you have understood this question. And if you did not understand, please let me know in the chat section. I can explain to you once again. And if you did not understand, please let me know what is that you did not understand. Then only I'll be able to answer you properly. Okay. Now, right. Yes, Varun. Good evening, Varun. Okay, so if you have understood this, then we will move on to the next question. Okay, so okay, the question is, this would be the better. Okay, Yeah. Allen's test. Allen's test is used to assess. Allen's test is used to assess radial artery, ulnar artery, palmar arch, brachial artery. Uh, yes, Esra, that is what I am telling you. Na? You have two answers, Esra. You have answer B and answer D, right? But if only one is asked to select, then go with B rather than D. Okay. And why is that? Because in D, at least the compensatory event you are having respiratory alkalosis. At least the compensatory event you are having respiratory alkalosis in the D. And what is given in our question is also respiratory alkalosis. But the primary event is respiratory alkalosis. But in your option D, the compensatory event is respiratory alkalosis. Okay. Right. Now, yes, Allen's test is used to assess. Right. So please remember, it is used to assess the patency of the ulnar artery. Right, it is used to assess the patency of the ulnar artery. And what is this particular test done for? See, Allen's test is done to decide, right, that is mainly to decide whether radial artery can be punctured or not for the ABG. Okay, whether the radial artery can be punctured or not for the arterial blood gas analysis. To assess that, you need to do the Allen's test. But Allen's test is actually, see, that means before doing the radial artery puncture, we do Allen's test. Why? That is mainly to assess the patency of the ulnar artery. That is mainly to assess the patency of the ulnar artery. Varun, it is not radial artery, Varun. It is ulnar artery. It is ulnar artery. Now, I'll just tell you quickly how we do the Allen's test. Right? How we'll do the Allen's test. Okay. So before going ahead with the Allen's test, you should know that, okay, so this is your ulnar artery and this is the radial artery. Okay, so this ulnar artery and radial artery, they are connected by the palmar arch. Right, they are connected by the palmar arch. Okay, now whenever you are doing ABG, okay, before that you should understand that radial artery, it will supply lateral 2.5. It will supply the lateral part of your fingers. That means it will supply thumb, it will supply the index finger, right? And it also supplies the medial part of the middle finger. Whereas the ulnar artery, it supplies the medial half of the fingers. Okay, medial half of the fingers. Okay, now whenever you are doing ABG, where will you puncture? You will puncture the ulnar artery. Sorry, I'm sorry, very sorry. You will puncture the radial artery whenever you are doing ABG. Now, once your radial artery is being punctured, what will happen? This lateral 2.5 fingers will not get the blood supply now, because with the AB, by doing ABG, you have punctured the radial artery. So lateral 2.5 will not get the supply now. Now, what comes for the rescue? It is the ulnar artery which will come for the rescue of lateral 2.5 fingers. So ulnar artery via palmar arch will supply the lateral 2.5 fingers of the radial artery. Okay, so if the radial artery is being punctured by your arterial bed gas analysis, what you should understand is that the lateral 2.5 fingers will be supplied by your ulnar artery via the palmar arch. That is what is the normal phenomenon. Then how will you do the Allen's test? So what you have to ask the individual is, first the individual has to clench the fist, and both radial artery and as well as ulnar artery are occluded. Both are occluded. So when both are occluded, okay, either in a clench, and once you occlude, then you ask the individual to open the palm. So you can just see that the palm is being pale. Why? Because radial artery is occluded and even the ulnar artery is also occluded. Okay, now what you should do now, you will release the radial artery pressure. right? You will release the radial artery pressure. Okay, so once you release the radial artery pressure, what should happen in a normal individual? In a normal individual, the medial half also should become red, right? The medial half also should become red, and even the lateral half also should become red. Why is that? That is because, right? That is because the radial artery, that is because the radial artery will supply the lateral half, and it is also giving the supply to the medial half via the palmar arch, right? Via the palmar arch. Now, once you have done this, what is the next thing that you have to do? Right? What is the next thing that you have to do? What does this mean? The next thing what you have to do is you do it in a alternative manner. Now what is that you will do? What you have to do is now release the ulnar artery, right? Release the ulnar artery pressure. Once you release the ulnar artery pressure, again the same thing, the entire palm should become red. If the entire palm becomes red after releasing the ulnar artery, that means your ulnar artery is patent, so you can comfortably puncture the radial artery. You can comfortably puncture the radial artery. Okay, right? Yes, Esra, see, the blood supply stops permanent or transient. See, the blood supply which is being stopped, it all depends upon the severity of the puncture that you will be doing. If the puncture is deep for a prolonged time, like for example, when you are doing a coronary angiogram through radial artery, when you are doing coronary angiogram through radial artery, you are occluding the radial artery for longer time, then there can be permanent loss of blood supply. But whereas when you are doing an ABG, arterial blood gas analysis, you are puncturing the radial artery for a short period of time, then the loss of blood supply will be only transient. It all depends upon how long you are occluding the radial artery. Okay, right. So please remember, Allen's test is done to assess the ulnar artery, not the radial artery. Okay, right. Yes, Varun. Sir, for radial. Right. Now I'll just put another question. Yes, Varun. A question which makes your question, which makes your doubt little comfortable. Okay. Now you answer this question. Yes. Allen test is used to assess the integrity of. You see the question. Allen's test is used to assess the integrity of. Then what will be the answer? I have added a word here, integrity of. So once I have added the word integrity of, then this becomes the palmar arch as an answer. This becomes the palmar arch as an answer because it is the palmar arch which is integrating the radial artery and as well as the ulnar artery. Okay, so this is the palmar arch. So the answer will be C here, right? Okay, now after having discussed about the questions related to the ABG, let me just move on to the gaps. Okay, let me move on to the gaps. Right. Now, if you take the questions related to the anion gap, so in the anion gap, I will be discussing, right. Okay, so in the anion gap, I will be discussing like corrected anion gap, then anion gap as such, then I will discuss the delta gap, then I will discuss how to make out whether it is an acute or a chronic event. How to make out an acute or chronic event. Let me discuss all these now. Okay, right. So all of the following cause high anion gap, metabolic acidosis except lactic acidosis, salicylate poisoning, ethylene glycol poisoning, ureterosigmoidostomy. So for this though you have some standard mnemonics. Right, very good, Geetanshu Kapoor. The answer is the ureterosigmoidostomy. Acha. Yes, Radhashri, if you did not get the one with annotations in my Telegram channel, then I'll post with annotations. Immediately after the class, I'll post with annotations. Okay. Just give me half an hour. Immediately after the class, I'll post with annotations. Okay. So for this, like what is this? This is high anion gap metabolic acidosis. So high anion gap metabolic acidosis. What is the normal anion gap? So normal anion gap, so this is around 8 to 12 milliequivalents per liter. Okay, anything more than that will be the HAGMA. Anything more than 12 to 14 milliequivalents per liter, we call it as the high anion gap metabolic acidosis. And if the anion gap of the individual is 8 to 12, we call it as NAGMA, that is normal anion gap metabolic acidosis. Okay, now let us just consider some questions related to HAGMA and as well as the NAGMA. But before that, what are the conditions which will cause HAGMA? What are the conditions which will cause NAGMA? So these are the standard mnemonics which I have said you previously also, right? You take this HAGMA, high anion gap metabolic acidosis, right? If I am not wrong, you are aware of this particular mnemonic, that is mud piles. So just remember, it is cat mud piles. Cat mud piles. Okay, so you can go through this. You can download the PDF and you can go through the mnemonic with the conditions which will cause the HAGMA. Then what are the conditions which will cause the NAGMA? That is normal anion gap metabolic acidosis. And what is the mnemonic for that? The mnemonic is the used car. Okay, so you can go through all the events which will cause normal anion gap metabolic acidosis, right? So having said that, now let us take up some questions related to anion gap and as well as the corrected anion gap. Okay, right. Yes, answer this. A 10-year-old boy with short stature presented with polyuria, polydipsia. Lab values are pH 7.34, carbon dioxide 32, bicarbonate 16, sodium 140, chloride 114, blood urea nitrogen 140, creatinine 1.8. What is the likely acid base abnormality? Okay, so please answer this question. Right. So now how to calculate the anion gap? So if you take the pH of this individual, the pH is 7.34. Okay, how much is the normal pH? Right, 7.36 to 7.44. That means the pH is reduced. Then what is the normal carbon dioxide value? That is 32 millimeters of mercury. Okay, in this patient. And what is the normal value? 36 to 44. So that means it is decreased. And bicarbonate, right, bicarbonate, it is 16. Even this is also reduced. So when both of them are changing in same direction, what is the primary event? The primary event will be metabolic. Metabolic, what? The pH is reduced. So when pH is reduced, we call it as acidosis. So it is primary metabolic acidosis. Primary metabolic acidosis. Okay, now whenever there is metabolic acidosis, we need to calculate the anion gap, right? We need to calculate the anion gap. So how do you calculate anion gap? That is sodium. Okay, sodium minus chloride plus bicarbonate. That is the formula for the anion gap. So how much is the sodium here? The sodium is 140 minus how much is the chloride? 114 plus bicarbonate, that is 16. So this will make you to get an anion gap of 10, right? So when anion gap of 10 is there, so what do we consider it as? Non-anion gap metabolic acidosis or anion gap metabolic acidosis. So there is slight confusion in your options, but what do you think will be the best answer? Right, very good, Trilok Chand. So the answer is the non-anion gap metabolic acidosis. Okay, non-anion gap metabolic acidosis. So when I mean the word anion gap metabolic acidosis, I mean it as high anion gap metabolic acidosis. Okay, right, because in the second option itself I have given you as non-anion gap or normal anion gap metabolic acidosis. So the answer here is B, it is not your C. The answer here is B, not C, because how much is the normal anion gap? That is 8 to 12 milliequivalents per liter. So when anion gap is around 8 to 12 milliequivalents per liter, then why do we consider it as the high anion gap when the anion gap of the patient is around 10? So the answer is non-anion gap metabolic acidosis. Okay, right. Now I'll just show you one more question, that is corrected anion gap. Okay, what do you mean by this? Corrected anion gap. So this is another very important area that you should be very much aware of. Just give me a minute, I am just opening that question for you. Right, answer this question. Same question again, but only thing I'll just tell you like what I have added there. What I have added there is the albumin levels. Okay, so 10-year-old boy with short stature presented with polyuria polydipsia, lab values the same thing like whatever I have given you in your previous question, but albumin level of the patient is 2 grams per deciliter. What is the corrected anion gap? 16 milliequivalents per liter, 18 milliequivalents per liter, 20 milliequivalents per liter, 22 milliequivalents per liter. So please remember that there is lot of influence of albumin levels on the anion gap. How much is the normal albumin level? The normal albumin level, like we consider it as around 4 to 6 grams per deciliter. 4 to 6 grams per deciliter. Okay, so the patient albumin level here is 2. That means albumin levels are reduced. Now the question is, in what way the albumin is useful? Note that albumin is the principal unmeasured anion. What is anion gap actually? Anion gap is nothing but it is a measure of unmeasured anions and unmeasured cations. And albumin is a principal unmeasured anion. So when albumin levels are reduced, then we don't get a standard anion gap. What we get is a corrected anion gap. Now, how to calculate the corrected anion gap? So, anion gap corrected is equal to anion gap of the patient plus, this is the formula that you have to know, 2.5 multiplied by 4.5 minus the actual albumin levels. This is a formula for corrected anion gap. So how much is that? See, anion gap, what did we calculate in this patient just previously? That is 10. So 10 plus 2.5 multiplied by 4.5 minus 2, because albumin value is 2. Okay, so this comes around 10 plus 2.5 into 2.5. Okay, 2.5 into 2.5. Okay, so how much will be this 2.5 into 2.5? This will be something, if I am not wrong, 10 plus 6.25. So what will be the value here? 16. The answer is A. The answer is A. So this is how we need to calculate the corrected anion gap, right? So this formula you have to remember to know the corrected anion gap. Okay, so corrected anion gap is equal to anion gap plus 2.5 multiplied by 4.5 minus the actual albumin levels in grams per deciliter. But when will you calculate the corrected anion gap? Only when the albumin levels which are given in the patient is, if it is reduced, then we calculate this corrected anion gap. Okay, now after having discussed about the anion gap and corrected anion gap, the next thing that you need to know is about the delta gap. Okay, next thing that you need to know is about the delta gap. So you see, this is the ABG of the patient which has been given. So ABG is like 7.23. Okay, sodium 123, chloride 97, bicarbonate 7, blood urea nitrogen 119, creatinine 5, albumin 4. What is the delta gap of the patient? What is the delta gap of the patient? Now, how do you get the delta gap, right? What is the formula for the delta gap? So the formula for the delta gap is that it is the actual anion gap minus 12 plus bicarbonate. See, there are many books which have given different formulas for calculating the anion gap. But what I felt was this is the best formula to calculate the delta gap. So actual anion gap minus 12 plus bicarbonate. And how much is the actual anion gap? So for that you need to know 123 minus bicarbonate 37, and how much is the chloride value? 97. Okay, so plus bicarbonate, how much is the bicarbonate value? That is 37. So that becomes the delta gap. Now if you calculate this, the value that you will get is, right, the value that you get is 14. The value that you get is 14. Now what is the importance of the delta gap? What is the importance of the delta gap? See, when will you calculate this delta gap is that, just give me a minute, 1 second. Okay, first of all, let me explain you the concept of anion gap. When will you calculate the anion gap? When will you calculate the anion gap? You will calculate the anion gap, right? You will calculate the anion gap if there is metabolic acidosis in the patient. And in this metabolic acidosis, you need to know like how many unmeasured anions and unmeasured cations are there. Depending upon that, you will be able to assess what type of metabolic acidosis is that. Is it like normal anion gap acidosis or the high anion gap metabolic acidosis, right? Now, that is the concept of your anion gap. Then what is the concept of your delta gap? What is the purpose used for? Delta gap is essentially a tool to determine whether or not there is also normal anion gap metabolic acidosis which is being present or not. Okay, I'll repeat the point again. Delta gap is essentially a tool to determine whether or not there is also a normal anion gap metabolic acidosis which is being present or not. That is the purpose of calculating this delta gap. Okay, right. So this is the question in response to Abir Asari. So you have asked me what is the importance of these things. So that is what I am trying to explain to you, right? So yeah. So if you take the delta gap, I'm sorry. Yeah, bicarbonate value is 7, right? Thank you, Elsa. So the answer in this question will be 14. The answer in this question is 14. So that is about the importance of the delta gap, right? So in this session, like what all we have discussed, like we have discussed the anion gap, corrected anion gap, then delta gap. Now the last thing in this session that I wanted to discuss with you is about the, right, about the acute events. So you see this question. For an acute increase in partial pressure of carbon dioxide to 60 millimeters of mercury, what is the expected increase in bicarbonate? What is the expected increase in bicarbonate? See, what is the average value of your PaCO2 we take? 36 to 44 is the normal value, but the average value that we take is 40. Similarly, bicarbonate, the normal value is 22 to 26, but average value that we take is 24. Average value that we take is 24. Now, please tell me what is the expected increase in the bicarbonate? Expected increase in the bicarbonate. Yes, anyone want to make an attempt of this question? See, this is an acute event. This is an acute event. So, okay. So, what is this acute event now? This acute event is acute respiratory acidosis. Acute respiratory acidosis. Okay. Now, when there is acute respiratory acidosis, there should be an acute change in your bicarbonate also. Acute change in your bicarbonate also. Okay. Now, what will be that acute change in bicarbonate? So, that is change in your bicarbonate. What is the formula for acute respiratory acidosis? For expected increase in your bicarbonate. For expected increase in your bicarbonate. Okay. So, that is 0.1, right? 0.1 multiplied by change in your carbon dioxide value. That is the actual carbon dioxide minus the the average value, average carbon dioxide value. So if you see this 0.1 multiplied by 60 minus 40. So this comes around 2. This comes around 2. And what is the formula for the expected bicarbonate? The formula for expected bicarbonate, what is that? 24 plus, right? 24 plus this formula. That will be 26. Okay, I'll explain to you once again. Please don't get confused. So, whenever there is acute increase in your carbon dioxide, we call it as acute respiratory acidosis. And whenever there is acute increase in your carbon dioxide, even your bicarbonate also should increase acutely. Average value of your bicarbonate is 24, right? So, what is the expected bicarbonate increase? The formula for the expected bicarbonate increase is 24 plus this formula need to be added. 24 plus change in your bicarbonate. And how much is that change in your bicarbonate? 0.1 multiplied by actual carbon dioxide minus average carbon dioxide. So the value that you get is 24 plus 2. The answer will be 26 milliequivalents per liter. Now, the same question you see for chronic increase in your partial pressure of carbon dioxide to 60 millimeters of mercury, what is the expected increase in your bicarbonate? So what do you mean by the word chronic? That means the carbon dioxide which is elevated to 60 millimeters of mercury is there in the individual for a prolonged period of time, right? For a prolonged period of time. So what should be the expected increase in your bicarbonate? So whenever, what do we call this as now? This we call it as the chronic respiratory acidosis. So whenever there is chronic respiratory acidosis, what should happen to your bicarbonate? Even bicarbonate also should increase. There should be chronic metabolic alkalosis, right? Chronic metabolic alkalosis. Now, for chronic respiratory acidosis, what should happen to your bicarbonate? It should increase. Now, what is the formula here? So here, the expected, yes, anyone want to make an attempt of this question? So, expected bicarbonate is equal to 24 plus, right? 24 plus change in your bicarbonate value. Okay. So now what is the formula that we have used for acute? I'll revise once again. For acute, we have taken 0.1 multiplied by actual carbon dioxide minus average carbon dioxide. But for chronic expected bicarbonate value, please remember like 24 plus 0.4 multiplied by the actual carbon dioxide minus average carbon dioxide. This will give you the expected bicarbonate value for chronic events. So what is the difference here? In case of acute respiratory acidosis, you have taken 0.1 there, but for chronic respiratory acidosis the formula is 0.4. That is the only difference that you have to remember. Okay, so now how much it will become? 24 plus 0.4 multiplied by how much? So this is around 20, right? So 24 plus 8. 24 plus 8, so that becomes 32. Okay, that becomes 32. So the answer to this question is 32 here. So whatever you have said, Trilok Chand and as well as Abir Siri, that 32 is for chronic. 32 is for chronic, but for acute, what is the expected bicarbonate increase? That is 26. Okay, so the difference is this one. For chronic, 0.4 you have to multiply with, but for acute you need to multiply with 0.1. That is the difference in the expected bicarbonate value in acute respiratory acidosis and as well as the chronic respiratory acidosis. Okay, so with this, like, I'm done with this particular session. So like, if you just see in the first part of the acid base interpretations, like how to determine the primary, how to determine whether it is fully, partially or uncompensated event, and in the second part of this ABG, like I have discussed about the anion gap, I have discussed about the delta gap, then I have discussed about whether how to make out acute and as well as the chronic. Okay, so with this I'll wind up this session, and if you have any doubts you can just text me on my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba. And not only that, I'll be also posting this particular PDF even in the Facebook channel of DBMCI. Okay, so you can download this PDF even from DBMCI channel, Facebook channel as well. Okay, so thank you very much, good night, and see you in the upcoming sessions.